I think that inadvertent or not, a lot of the issues come from the medical field just not treating people with the respect that they deserve and not, giving people the rights that are afforded to them to, do what they want with their medication, especially if it's not something that really has a high liability in terms of harming other people.
You're listening to Narcotica, a podcast giving you the straight dope about drugs and the people who use them.
If you ask many people whose lives have been upended by opioids, buprenorphine is a lifesaver. It can literally cut the risk of a fatal overdose by half or more in folks who have an opioid addiction. Also known as Subutex or Suboxone, buprenorphine is an opioid. It's one of the 3 FDA-approved medications to treat what's formerly known as opioid use disorder. It's a partial agonist at opioid receptors, relieving cravings with far less risk for overdose than other opioids like heroin, which are full agonists. I'm Troy Farah, and you're listening to Narcotica. With me today is Zachary Siegel, beaming from Chicago. Zach, how's it going?
Hey, pretty good.
And we also have Chris on the program today from Kensington in Pennsylvania. How's it going, Chris?
Yo, hey, how's it going, guys?
Today on the program, we have Molly Doernberg, a grad student at Yale School of Public Health who co-authored a recent paper called Demystifying Buprenorphine Misuse. Has fear of diversion gotten in the way of addressing the opioid crisis? It was published in the journal Substance Abuse last April. The paper addresses some of the hand-wringing from media and policymakers about the alleged risks and so-called diversion of buprenorphine, one of the best tools available for addressing the current overdose emergency. Today we're going to talk about what buprenorphine is, why people take it, and why stigma and fears that buprenorphine may be used illicitly are actually contributing to more overdose deaths. Molly, welcome to the program.
Hi, thanks for having me.
So I really liked your paper, and so it starts with all the ways in which buprenorphine is overly regulated, and it makes it difficult for doctors to prescribe it and difficult for patients to get it. It also argues that fears of diversion are overblown and reinforce all these barriers. And so you and your colleagues write, it is rare to find a media article about buprenorphine that does not mention diversion or misuse. And yet, compared with most opioids, buprenorphine has a very high safety profile. So can you start by describing what diversion is and why the media and especially the law enforcement community so often harp on it?
Sure. So diversion is sort of any non-prescribed use of the substance. So, either by use not as prescribed by the person for whom it was prescribed or for other people. And I sort of got interested in this. So this summer, I worked for an organization called the Behavioral Health Leadership Institute that works specifically to improve the delivery of addiction services in Baltimore. And one of their projects, they run a treatment van called Project Connections at Reentry. So they come right out the door, the release gate at the detention center, and can come right into treatment. And that was done specifically because treatment was not being allowed in the facility itself, because there was a lot of kickback from correctional officers and wardens and things like that because of diversion. So, the obvious sort of more logical and probably better solution, which is to implement it in the facility, was not being accepted. And so that kind of led to this alternative solution to have this treatment van parked outside of the release gate. But that was really kind of interesting that, knowing what we know about buprenorphine and other medications and how effective they are and the great things that they can do, that there was still so much resistance to particularly implementing it in criminal justice settings and other settings like that, where people really don't have access to what they need. So learning about kind of this panic about diversion and that it was this horrible thing that was causing all these problems and leading to deaths and overdose and all these things. And figuring out that that really isn't true, and that it's a lot of myths and a lot of situations being overblown, and kind of putting into actual perspective what risks are caused by buprenorphine, and realizing that they're not many, was kind of what inspired this whole piece.
Thanks so much for this paper. I live in Philadelphia and spend a lot of time in Kensington, which is awash in fentanyl mostly now, heroin, and all kinds of other synthetics. There's an awful lot of Suboxone diversion, primarily because it's just not quite powerful enough to handle the high tolerances that many people have. So while buprenorphine's been favored, I think, certainly by the current administration over something, say methadone, a lot of people will be put on buprenorphine, and they invariably sell it. And I've had many discussions with our transit chief here, the chief of our transit police, who is kind of largely the only one really enforcing this to some extent, because a lot of the sales go on in his jurisdiction right around the train areas, where the people come off the L, and there's a lot of Suboxone for sale there. And I've tried to impress upon him that this is something that he might want to consider backing off, because it's sort of, in my opinion, and what I've seen in my observations, is generally people will buy this as sort of in case of emergency, if they're going into jail, or to hold them for a day or two. I don't see anyone actually, using this as a drug of abuse from where I'm sitting.
Right.
So to me, we need. I would go so far as to say we should encourage Suboxone diversion to the extent that we can, because it's one less chance of an overdose.
Yeah, I mean, I definitely think in the absence of better options, there's no reason that we or anyone should be turning their nose up at something that appears to be working.
Right, I agree, and I find that like I said, there is often two camps, and then there's of course the abstinence camp. I don't think it needs to be that way. I would prefer an individualized treatment, but when it comes to diversion, we're obviously not going to see much methadone diversion is handled, in a completely different way.
I think buprenorphine is interesting because it's so heavily regulated, yet it seems like it's one of the best tools for treating opioid use disorder. There are other drugs, of course, methadone, naltrexone, and some would even say kratom. But despite its effectiveness, buprenorphine is treated like plutonium. It has all this stigma attached to it, which is kind of bizarre. I kind of want to unpack that a little bit. Just to give an example of how out of touch public officials are on this issue, Tracy Helton, she's the author of The Big Fix, recently tweeted, "Last year I got invited to a panel on harm reduction held by the criminal justice folks. I'm from the health department. The official San Francisco policy is harm reduction. One of the panelists argued against medication-assisted treatment, harm reduction, and said people on buprenorphine shouldn't be around children. In June, they are giving this person an award." And I've experienced that personally, too, with methadone specifically. Like, a friend got a hold of some methadone, and another friend was concerned and said, he's got heroin in a pill. Can we talk about some of the stigma and where it comes from and how to address it?
People are afraid of what they don't understand, and so they lump all these things in together and assume that people who have had substance use issues are gonna have issues with all substances regardless of what they are, and obviously we know that's not true. But I think people are pretty ignorant about the good that these medications can do, and the fact that having that responsibility to take those medications is something that you can entrust to other people. And if they don't want to take them if they have other reasons for diverting them, if they have a friend who needs help managing withdrawal or something like that, then we should trust that people are using them for something that they need to be used for, even if it's not what people in the medical field sort of think that they should be used for. Because like you said, nobody's really using these to get high off of. That's not really something that you can do. And there are abuse deterrent formulations specifically to address that concern, that it's really hard to really misuse buprenorphine, specifically like Suboxone versions, which are buprenorphine and naloxone together. So, you know, I think I was really struck by how really overblown these fears were, given what we know about it, and given that how we know people are using it, which is mostly to self-treat in the absence of access to better care.
Yeah, I think a lot of the stigma does come from sort of what you were saying, like people just don't understand it, and there's a lot of misinformation out there. And a few weeks ago in the Columbia Journalism Review, I reported the results of a study that basically analyzed media coverage for over the last decade or so. And what it found was that, like, in more rural areas, the local journalism was more negatively slanted against medication treatments than like national news outlets. And when you go into the
Mm.
local news, and your paper sort of does this a little bit in the introduction, you do see that the people quoted are like prosecutors and judges and drug court judges and people who are really focused on this diversion issue and sort of invoke moral hazards, like if we make this drug more available, it's going to lead to more of a bigger black market, it's going to lead to more misuse, and it all of this sort of belies the fact that there's an overdose emergency happening, and this drug and other drugs like methadone have the ability to substantially reduce the death rate. So I think a lot of that is coming from like the law enforcement community, and this gets mixed up in articles where the local journalists are not quoting doctors and medical professionals. They're quoting people who see buprenorphine as like just another nail to hammer.
I think, you know, even if you're going to take the viewpoint that even if you're not going to believe, you know, people telling you how they're using it and what they're using it for, there's a lot of recent evidence-based research that's come out. We cite a lot of them in the paper that, you know, like 60 or 70% of people who divert their buprenorphine are, you know, giving it to a friend who can't get access to treatment, or using it on a different schedule because it's not managed well. And so, you know, even if you're not going to believe what people are telling you, there's been more research on this. And it's, I mean, I just don't understand how people can really argue with the research and still just try really hard to find fault with diversion.
Yeah, I think the irony is that some of these rural populations that where you probably find the most stigma also have the least amount of experience with medication-assisted treatment because it's so unavailable in many cases. I'll say it's nice to live in a city where that's progressive enough to give our jail population Suboxone. That being said, I did an interview a couple of days ago about the Indivior case, and I mean the real scandal here is you know how high priced and how hard these pharmaceutical firms fight to keep generics off the market, in my opinion. So it's turned into a real cash cow for some doctors. It's turned into a cash cow for Indivior. There's finally in February, I think, a new strip hit the market. But for the most part, you know, even the formulation of naloxone and buprenorphine, two off-patent drugs, was kind of like a sleight of hand because the naloxone does very little unless you already have a serious, you know, pre-existing, opioid habit. It's not going to stop an initiate from beginning to take Suboxone for whatever little nod they might get. And we found here in Philly that the only place that was abused was in jail. So they came up with a really radical scheme. Let's just give it to them. So now that doesn't mean that there aren't people that will still take just about anything they can to feel a little different. That's humanity. But I think it is important to nail home that point that while we're focusing on the users that need it, you know, I think too little attention has been placed on how it's been more than a decade since its approval, and the cost of a strip of Suboxone twice as much as the cost of a bag of heroin on the streets of Philadelphia.
And I think another thing that just seems really logical to me, but I'm so curious about why it hasn't really clicked for the people running these sort of crackdowns on diversion, is that, by doing that, you're driving the illicit market by putting all these regulations and restrictions on getting legal access to medications. You're creating part of the problem. So if there's not enough waivered prescribers, there's patient caps, there's long waiting times, there's step therapy, which is like that whole fail first model. There's, I think, like a dozen states have limits on lengths of time that you can be on buprenorphine. Implementing all those things out of a fear of diversion is just making the issue worse. And that the best thing you could probably do if you're really looking to kind of cut down on the amount of medication diversion, is to make it more accessible to everyone.
So for me, that raises the question, is this evil or ignorance? Like you said, how can people ignore this science? Like, you literally go to Google Scholar, type in buprenorphine or buprenorphine diversion, you just read about this. It's all there. You can know about it. So all these obstacles that are put in place that are creating more barriers to people seeking treatment or even just not dying. What would you say? Do you think it's malignant, or just people are that lazy to look it up?
I mean, I'm not really sure. I think that, from sort of a public health place, public health and medicine don't have a great track record of treating people who use drugs with respect. And I think that there are a lot of assumptions made about, can you give people who use drugs the responsibility of taking home medication? And and I think that there's been this whole history of making it hard for people to want to be in a medical setting, in a clinic or a hospital. And so I think that, inadvertent or not, a lot of the issues come from the medical field just not treating people with the respect that they deserve, and not giving people the rights that are afforded to them to do what they want with their medication, especially if it's not something that really has a high liability in terms of harming other people. And I think that has to be something that really has to be changed from the medical and other related fields within that, so that people don't feel so uncomfortable seeking legal access to medications and telling their providers if they have diverted it and why. I work at the Addiction Recovery Center, which is a clinic out of a hospital in New Haven, and there's just the guy who runs the clinic is just so phenomenal, and that patients just have no problem telling him, being honest with him about if this week they used, or if this week they gave away their medications, because he's really understanding and doesn't cut them off, doesn't ban them from the clinic. But that's still the case in a lot of places, that the first time your urine toxicology test comes back abnormal, so whatever you should be taking is not in there, or whatever, that you're banned from the clinic, you're put on sort of a probationary period, you're kicked off your medication. And that, I think, is really irresponsible. And I think that that's not creating an environment where people feel like they can be forthcoming if they feel like their medication's not being managed well, if they know other people who are having trouble getting access to it. So I think that's something that we have to take responsibility for, as health professionals, and fix that.
I think like a really good counterexample to sort of America's very restrictive regulatory environment for this drug is France. So like France had a big HIV crisis that was connected to injection drug using. And after initiating basically like a national low threshold model that was basically buprenorphine on demand for whoever needs it whenever they ask for it, from 1995 to about 1999, the number of overdose deaths in France declined by 79%. And obviously they have a very different medical system, one that like actually functions, not like America's, but it's still like there is a way, there are counterexamples around the world of countries that don't take this punitive, puritanical approach to drug use and see very good outcomes. And I always invoke France as one that did it.
Not to keep beating up on the pharmaceutical industry, but it's really like a follow the money issue. I mean, everything that you just mentioned, Molly, kicking people off of the clinic, that is counter to the messaging coming out of regulatory departments on this. On how we know, for instance, now that it's okay to prescribe benzodiazepines along with Suboxone. And yet there are still individual doctors that believe it's not, or that find that to be dangerous. So we have Sublocade now coming out. So this medication compliance issue, this diversion issue, I mean, ultimately that's going to benefit. I've had addiction doctors tell me, you just wait. Eventually insurance companies aren't even going to cover like oral Suboxone anymore once the Sublocade hits, or because of this fear, right? So. Not to make it this big conspiracy theory, but really there's only one organization or sort of like, group of companies that will benefit from this idea. Well, there's only one company or two that now have injectables that are ready for market. And you have to ask, who benefits from this fear? Certainly not the people that are the people and families that are impacted by addiction. The messaging coming out of Washington and the FDA and SAMHSA is like, don't kick people off because they come back hot. There's counties that have stopped prosecuting diversion, at least one, I believe, in Vermont. So it's sort of questionable to me, like who's even continuing to perpetuate these myths.
Yeah, and I really don't know. I mean, I think a lot of it, again, like I don't know a lot about the pharmaceutical industry, but I know that from what I've seen, it's a lot of, again, prosecutors, police officers, a lot of issues in correctional facilities in terms of correctional officers and wardens and things like that. And even commissioners. I mean, where I worked in Baltimore, I think we're really fortunate. They had a really great, progressive, forward-thinking commissioner, but he wasn't able to get anything through because the COs are unionized, and they said, we don't want to deal with this because of what we've heard about diversion. And so he wasn't able to get anything through. So I think that there's a lot of misinformation, lack of information, general ignorance, or I guess probably in some cases not wanting to believe the evidence or the science that really prevent us from making positive changes and doing anything meaningful in this area.
On the topic of positive changes, in your paper, you bring up the topic of mobile treatment sites. I think an overlooked aspect of drug use is that many heavy drug users are isolated from society, and part of that isolation facilitates self-medication with opioids or stimulants or whatever they have. It's not about euphoria, it's about survival in this complex, hostile, and sometimes violent late-stage capitalist environment. So some people are pretty removed from things like the healthcare system, and if we want to help them, it makes sense to bring treatment to them with these mobile treatment sites. So tell us, what would these, if they're hypothetical or if they're functioning anywhere, what do they work? How do they work ideally?
So the organization I interned with had a couple such vans, and this one I talked about briefly that's outside of the detention center. But it's basically this, like, I know it's referred sometimes as a hub and spoke model, where rather than sitting in your ivory tower, clinic, hospital, whatever, and making people come to you, and for so many reasons, there are 100 barriers to that, perpetuated by the healthcare system and otherwise, but rather than saying, we're going to sit here in our offices and you can come find us if you want care, this whole spoke model, which is just branching that out and in whatever avenues possible, bringing care to people where they are. And then I guess the hope would be eventually they get really comfortable in that situation, or they become more trusting of people who are providing their treatment, and they can transition to a different type of facility. But that's also, I've talked with some people where that's not even their goal. If you're comfortable in seeing someone in a mobile facility, then there's no reason to kind of shuttle you to a freestanding place. And also, so this organization that I was working with in Baltimore, so what they do is that they partner with grassroots recovery programs, and then will offer medication. They'll have, you know, a doc, a nurse, come in like 1 day a week to each of these locations, and just start offering treatment out of whatever grassroots organization is already there. And so they do that in a couple places that host, you know, like peer recovery support groups, that do like employment assistance, housing assistance, and they'll just kind of really kind of bare bones show up with like a doctor and a nurse and a peer support specialist, and like 1 day a week people can just come and check in with them, and they can do inductions, and they can get people started, and you're not forcing people to come seek you out if they want to get treatment. You know, it's your job to go find them and make it accessible to them, especially in a field that like has a history of not doing that. So I think that model has been really successful in Baltimore. I don't know where else it's happening, but I think it would be really great elsewhere to just kind of eliminate some of the many barriers to getting treatment in a hospital or clinic setting that's really just so inaccessible to so many people. And there are also there are a lot of rules with a lot of treatment programs that are more rigid or more established. You know, you have to attend groups, you have to do urine toxicology tests, you have to, you know, do X, Y, or Z. And for people who are not interested in doing all those things, there's no reason they shouldn't be able to get treatment anyway. And so I think doing sort of low barrier, low requirement, easy access treatment through mobile facilities, or these kind of once a week coming in to already existing organizations, are good ways to just get people the medication that could save lives without putting all of these conditions on it that a lot of existing programs require.
Yeah, it seems like taking the treatment to where people are is sort of like the non-metaphorical meet people where they're at kind of thing. And it's also, I think, goes a long way to building that kind of trust that you alluded to earlier in the show that has been strained by public health in the medical community with respect to drug using populations. I mean, there's little reason for anyone using drugs to like trust a doctor or trust someone who's offering them help. They've probably been burned in the past, right?
And ironically, when sometimes one policy clashes with another, so we have a mobile Suboxone unit here in Philadelphia, and when, you know, we had a series of camps, homeless drug user camps, and it was really easy to just go there once or twice a week. Now they've been shut down, and people are just harder to find. You know, but looping back around to what you said about these barriers, this is almost an issue where we need to begin enforcing regulations rather than, and what I mean by that is, you know, for instance, you know, under federal law, even outpatient treatment facilities only are required to do 8 urinalysis tests a year, right? So Suboxone is a Schedule 3 drug. It is available for up to 5 refills. So, you know, we could make it a lot easier for people to get and receive and benefit from buprenorphine, and if we simply enforced the regulations that they exist under. So, you know, there is really no reason for somebody to go back to a doctor every 2 weeks or even every month to get a prescription. And I think that's like kind of an irony is there's almost either self-censoring, doctors are afraid to get in trouble, or in some cases, and I've seen it, there are doctors that are simply profiting off of monthly visits, and, you know, that only accept cash for payment. And that's unfortunate.
Yeah, I mean, I think, you know, there's two parts to this. And one is that there's so many existing restrictions and regulations associated with these medications that adding more makes no sense. And then so not only should we not be adding more, but we should also really be working to dismantle some of the existing ones that just are not effective, don't have any meaningful purpose, and are just really adding more reasons for people to not want to seek treatment. And, you know, I can only imagine, I feel like that, you know, probably the majority of Americans don't feel comfortable in medical settings for numerous reasons. It's not, you know, they're difficult environments to navigate. And so I just think that adding all of these reasons why, putting all of these barriers between you and what you need just makes it that much more difficult for people to get to where they need to be. And I think there's kind of, for me, those two elements of, moving forward, policies should not further restrict access to medication. We should also be working to undo some of the regulations that are associated with these prescribing these medications and taking these medications, because a lot of them are kind of needless, I would say.
So have you gotten any emotional or empathic responses to this commentary? And what should people do if they want to help fix this problem of buprenorphine access?
So it's only been out for about 2 weeks. So haven't gotten too much feedback yet. I think people have been really interested in the idea that we're kind of going the wrong way with this. I think that there are some places in the country that are doing really innovative things. There's Baltimore, like I mentioned. I'm from Boston, which has a ton of really innovative things in this space. I actually got my start working at Boston Healthcare for the Homeless, which is how I got interested in substance use originally. And they're always coming up with new ways to make treatment more accessible to people. But I think, aside from that, there are just huge swaths of the country that just have no innovation in access to care. And I think that there's just a lot of misinformation, and that combined with the fact that, there's in medical hubs like Boston and, New York and Baltimore, it's easier to spread proper information because you have people who are experts in this, who really know what they're talking about, who are compelling in terms of making their case. But in areas where, in rural areas where you don't have anyone who's like an authority on, medication assisted treatment, or who knows a lot, or who's willing to put themselves out there and sort of go toe to toe with law enforcement or prosecutors or people who are working to limit this access, there's not a whole lot in terms of progressive action happening there. And so I think that, trying to bring some of these ideas that have popped up in some of these sort of medical areas that have a high concentration of hospitals and medical professionals, and making those possible to execute in places where there aren't as many resources is really important. So and I think also, I forget who mentioned it before, but, in a rural area where you have one doctor for hundreds of miles who can prescribe, those are the areas where issues around diversion should not be as policed, because if you're not making the medication accessible to people, if it's so hard to get, people have to travel for hours, there's only one provider, there's no way that you can have a sustainable model where people don't have to divert for a number of reasons. And so I think that working on simultaneously bringing more access to those areas, but also kind of relaxing those restrictions given what we understand about how the limited resources in those areas, I think kind of have to go together.
Yeah, and to sort of wrap up it and tie a bow on this, like all of the structural issues that really kicked off and kickstarted the overdose crisis like in the late 90s, like all of these structural problems in our healthcare are also making it so difficult to even treat the problem. Like all the insurance companies like incentivizing to treat complex diseases with just give them opioids and send them home. Like that kind of stuff got us into this mess. And now we're at a place where we're really trying to treat it, and our system and infrastructure just can't bear the weight. Like there's so, and especially if you're in like Appalachia or like the Ohio River Valley, which is like the quote unquote epicenter of this crisis, there's so many doctors who could just give you 30 hydrocodone and send you on your way. And those same doctors cannot give buprenorphine. It's sort of just like such a mess and infuriating. So thanks so much for taking time to write a very sharp and great commentary about these issues.
Thanks so much for having me.
Molly Doernberg. You can find her on Twitter at Molly, Doernberg, grad student at Yale, author of the paper Demystifying Buprenorphine Misuse.
All right. Thanks, everyone.
Thanks so much for coming on the show.
All right. Have a good one.
Thanks for listening to Narcotica. Narcotica is an independent production by Christopher Moraff, Zachary Siegel, and myself, Troy Farah. Our co-producer is Aaron Ferguson. and our theme music is by Glassboy. You can follow us on Twitter at Narcocast or on narcocast.com. If you like the program and you want to support us, there are a few ways you can help. Tell a friend about us. Most podcasts become popular via word of mouth, or give us a decent rating on iTunes, Stitcher, or wherever you get your podcasts. Second, you can become a patron at patreon.com/narcotica, where you'll get access to exclusive bonus content and help us pay our bills a little bit. We are so grateful for the people that make this program possible. We want to stay ad-free, and you guys help us do that. Thank you so much. If you want to send us a suggestion, tell us about using DXM to time travel, or just want to say hi, you can email us at tips@narcocast.com. That's all for now. Take care.